Welcome back, everyone, to this afternoon session of neurology. It is my great pleasure to introduce our first speaker, who will also be the moderator for this entire session, Dr. Galen Henderson. Dr. Henderson is Assistant Professor of Neurology at Harvard Medical School, and he is also the Director of the Neurocritical Care Unit in the Department of Neurology at Brigham and Women's Hospital. He is going to talk to you today about stroke, and I look forward to a wonderful, wonderful lecture from Dr. Henderson. Take it away, Galen.
Great. Thank you so much. Good afternoon, everyone. I'm here to talk to you about stroke, and this is going to be one of the most exciting talks, hopefully, that you hear all afternoon. I have no conflicts of interest to disclose. And here's the outline over the next 30 minutes or so. We will review issues of epidemiology, the new definitions of TIA, which type of imaging is the best for your patient, the new standards with catheter-based therapies, and we'll finish talking about issues of stroke workup and cardiac Holter monitoring. Here's some of the key points that I want to get across. That time that we used to use for TIAs, well, that's really kind of gone out of the window now. But it is important to note some of the new changes. And also, we're using dual antiplatelet therapies for TIAs and certain types of strokes. And we'll talk more about that. Also, we are monitoring patients much longer with Holter monitors compared to the typical 24-hour mark. And also, since we're dealing with infectious issues at times, COVID does cause a hypercoagulable state. Stroke in the United States is incredibly common. We see about 750 to 800,000 new and recurrent strokes each year. It is the number 3 cause of death, but it is one of the leading causes of serious long-term disabilities in the United States. And patients are frightened of being disabled. As patients get older, this is what they are frightened of. For those who have had events, we know that the 5-year stroke recurrence rate is incredibly high, ranging from 25 to 40%. The 5-year stroke mortality is very high, ranging 40 to 60%. But it is true that the number 1 cause of death in the stroke patient is heart disease. Heart disease is still the number 1 killer of all stroke patients. And also for that group that does survive, about a third of those patients, 4.5 to 5 years out, will have some elements of dementia. Even though people are concerned about Alzheimer's disease and Alzheimer's dementia, if your patient has had strokes or TIAs, please remember that vascular dementia is a possibility for that patient population. So just don't forget this in your consideration, in your differential for your patients. We're going to focus primarily on ischemic stroke, which is 88% of all stroke. It deals with the blood clot. We will not talk about cerebral hemorrhage or subarachnoid hemorrhage. Let's focus on the blood clot and what causes that blood clot to form. In forming that blood clot, the pathophysiology model is very different than that of heart disease. If you were to think about issues of heart disease, the pathophysiological model, if you look at this left side of the slide, you'll see issues of atherosclerosis. And yes, many of our patients will have some signs of atherosclerosis. But on the right side of the slide, you see issues of cardiac sources, atrial fibrillation, dilated cardiomyopathies, even prothrombotic disorders. So there are a lot of causes of stroke. The prothrombotic disorders like factor V Leiden, lupus anticoagulant, antiphospholipid antibody syndrome. You see vasculitis causing strokes, migraines causing strokes. So there are many, many different causes of strokes, many different causes of that blood clot being formed. And when we are evaluating each patient, we are evaluating what has made this blood clot form so we can try to treat that patient most effectively. Of the risk factors that you see here, there are modifiable risk factors and non-modifiable risk factors. For non-modifiable risk factors for age, after 55, for each successive decade, the risk of stroke doubles. For gender, males have more strokes than females. For race and ethnicity, those of African descent or Asian descent along the Pacific Rim, the risk of stroke is twice that of Caucasians, and Hispanics are in between. And if there is a family history of strokes, we want to be aggressive with controlling those modifiable risk factors that you see on the left. But in those risk factors on the left, which one of these are more important? We see that hypertension by far is one of the most important risk factors for stroke. I also want you to focus towards the bottom of the slide, looking at psychological factors. Stress and depression, they are just as important as diabetes, which is in the center of this slide. So for those who are in primary care, please take care of the entire patient, because in doing so, lowers that likelihood of the patient having a stroke by taking care of the heart as well as taking care of the brain. So everything is important for this patient population. We know that we see stroke prevalence increasing with age, and the older they are, the more likely they are to have strokes. But if you look closely, you'll notice that about a third of these patients are actually less than age 60. It is not uncommon for people who are ages 20, 30, and 40 to have strokes that we see in the hospital. 10 to 15% of our patients are considered young, some with risk factors, some without risk factors. But the causes are usually different in the younger patient compared to older patients. And we have to figure out why. And if you think you're busy now with stroke, just wait, because the populations is aging. The number of people 65 years of age and older, that number is growing, as well as those people 85 years of age. That number is growing as well. And if the rate of stroke continues as it is right now, probably by in about 4 or 5 years, we're going to have more than 1 million strokes per year. And one of the reasons why we're having so many more strokes is because we're better at making the diagnosis, primarily because of imaging. Imaging has really changed things. So let's start with a case. And this is a case that was published just a few weeks ago in the New England Journal of Medicine. So this is not my case, but hopefully there's some interesting things that we can talk about here. So this is a 54-year-old man who presents 2 hours after the sudden onset of weakness in his left arm, and it prevented him from turning the steering wheel while driving. His symptoms lasted for about 30 minutes, and he has a history of hypertension, hyperlipidemia, for which he takes angiotensin receptor blocker and a statin. He is a current smoker with a 30-pack year history. On examination, when you see this person, his blood pressure is 156/96. How should this patient further be treated? And here are some things to consider. Is this a TIA or not? Is this a stroke or not? Was this a migraine? Should we have given medicines or not? So you're seeing this person in the office with those blood pressures, those numbers, and that history. Let's go to our first question. Imaging. A, CT of the brain. B, CT and CTA of the head and neck. C, MRI of the brain. D, MRI of the head and neck. And I guess there is music, and we'll allow a few seconds for a countdown. Okay. We see that many have chosen the correct answer was MRI of the head and neck. So assessment scales to perform next. So now we have our MRI, MRA, of our head and neck. Which of these assessment scales should we perform in the office? The Glasgow Coma Score, B, the NIH Stroke Scale, C, the ABCD Squared Score, D, the FAST Score. Okay. The correct answer is C, the ABCD Squared Score. So in the imaging, this is the MRR that was obtained, and it shows small diffusion-weighted lesions, even though the symptoms only lasted for 2 hours. We see signs of ischemia here. In the old days, with the old definition of TIA of 24 hours, it would have been a TIA, an old-fashioned TIA. Now, with the new definitions, it is considered a stroke. And conclusions, the patient described in this vignette presented with symptoms of a motor TIA. That's what it says for the New England Journal, but we see ischemia on the MRI. Had spoken on the telephone. If they had spoken over the telephone, the doctor in the New England Journal of Medicine would have given this person or advised for this person to take 300 milligrams of aspirin if possible. Now this person is being seen with these lesions being seen. The next step is to give clopidogrel. So we are now using dual antiplatelet therapy based on imaging as well as clinical symptoms, and then aspirin. So when I say dual therapy, meaning clopidogrel and aspirin for 21 days, followed by just aspirin as monotherapy afterwards. And if there, of course, carotid disease that we can visualize from that imaging study, this person would be given the diagnosis of having a symptomatic carotid and would have an endarterectomy. And of course, if we were to see anything on Holter monitoring that suggests AFib, that would change therapy as well. Here is a pathway that was listed in the New England Journal, so I would advise you all to take a look at it. It only came out a few weeks ago. And this is the old definition of TIA within 24 hours, but this is the new definition that if symptoms last more than 1 hour, it is a stroke clinically, and it must be without evidence of acute infarction. So imaging is a core part of how we are evaluating things. This is how we manage or classify patients as high risk. This is the ABCD Squared Score of TIA. This is something to remember because it does change therapy. This is like the CHATS VAS score for AFib patients and determining if they need to be on anticoagulation. So if their age is 60 and above, they get a point. Blood pressure is greater than 140/90, they get a point. Clinical symptoms, duration of 60 minutes or longer. The second D is diabetes. And if they were to score 6 or 7 on the scale, their 2-day risk for having a life-threatening or disabling stroke is high at 8.1%. Do we admit these people to the hospital? Well, we think about it as chest pain. If they present within 72 hours of symptoms and they have an ABCD Squared score of 3 or greater, yes. Or if we can't work them up in the next couple of days, even with a lower score, we will admit them to expedite that workup. If the symptoms present greater than 72 hours out, we probably would get that workup as just an outpatient. In working up a TIA is the same as working up a stroke. There is no difference in the two. They're in the same spectrum. And let's talk about those. Which imaging is best to get? For the outpatients, it is really the MRI. For the patients coming into the emergency department that are still symptomatic, probably CAT scans, because we don't know if it's a hemorrhage or what it could be. Here are the 4 P's that we evaluate when it comes to imaging. The parenchyma of the tissue and the pipes, because after all, the problem is in the pipes. Let's look at the pipes, making sure those vessels are clean. With a CAT scans are great because they're fast, they're easy to get, they're very sensitive for cerebral hemorrhages. But even in the hyperacute phase, you won't see all that much. With MRI technology, with specifically stroke protocol imaging or diffusion weighted imaging, within minutes of having ischemia, you will actually see it on diffusion weighted MRI. So it's much more sensitive than than CAT scans for ischemic strokes, more sensitive to posterior fossa lesions, lacunar strokes. But the downside is that they are more difficult to obtain in those critical settings. Here are 3 patients. Their CAT scans are above. Their diffusion weighted imaging below. Large right middle cerebral artery stroke here, where the CAT scan looks normal. Thalamic stroke, patient number 2. Their CAT scan above, minutes earlier, looked completely normal. Normal looking CAT scan above for patient number 3. Multiple white matter changes in different vascular territories. So we are thinking whether or not this patient has atrial fib or aortic arch disease, throwing a shower of emboli throughout the brain in different vascular territories. This is how MRI technology can tell us really what's going on and give us a sense of prognosis much faster than CAT scans. Also, I'll make comments about the first 2 types of imaging modalities for the vessels. There are CT angiograms and MR angiograms. When a person gets a CAT scan, they already have an IV. We push the dye, and these are the kinds of images that we can get. And this is the image on the left is a gentleman with 30 minutes of slurred speech and a heavy arm, and had a threatened carotid occlusion. Exam was normal. There were no carotid bruits, nothing. The image to the right shows how we can look at these vessels in the emergency department, and we can clear all of the vessels in the neck before this patient is discharged. Also, we have to look at the intracranial vessels because 9 to 10% of patients, especially those who are diabetics, have more intracranial atherosclerosis. We need to know about this because this does change therapy. So what I'm saying is that we have to look at all of the neurovascular tree. We can't just do carotid Dopplers. We have to look at all of the vessels. They're all important. For those patients that are getting MRs of the brain, we want MRI or MRAs of the head and neck. And even if the patient has advanced kidney disease, they do not have to get gadolinium for this. This is a time of flight image, and we see the image on the left with a severe carotid stenosis, or the image on the right with an occlusion of the left internal carotid artery. So the guidelines say that MRI with diffusion weighted imaging is superior to non-contrasted CT scans for acute stroke. But in the real world setting, we have to use whatever we can. But in the emergency department, if the patient is symptomatic, yes, CAT scans are better. But if the patient had transient symptoms and now those symptoms are almost gone, we should really probably be getting the MRIs. We know that intravenous TPA is the gold standard for ischemic stroke, but there's that risk for hemorrhage, which is about 6% of patients. But even though it is effective, we know that in large vessel occlusions, LVOs, such as the middle cerebral artery or internal carotid artery or basilar artery, those arteries are larger, their clot burden is greater, and it's less likely to open those very large vessels. And so now we are using catheter-based therapies to open those vessels. The window for opening those vessels used to be as high as 6 hours. Now it is up to 24 hours. The way we choose these patients is with the history. but also with imaging. Imaging is a core part of how we make the determination of using catheters to go into the brain to pull the clots out. And so if we were to focus on the images towards the bottom of the slide, here is a diffusion weighted MRI. That tissue is gone and not to return. The red is the tissue where there is a delay in perfusion of blood to that hemisphere. And if we were to overlap those two images, the tissue in blue is the tissue that we could potentially save by going in and treating that individual clot. And we have been able to treat patients who are 80 years old, 90 years old, and my oldest is 101 that we treated with catheter-based therapies 20 hours into their symptoms. What I wanted to show you is just something pulled from YouTube. This is just an example of a 2-minute video of a cartoon of a patient either having a cardiac source or an embolic source from the neck and having a stroke. This is the clot lodging in the middle cerebral artery. The patient becomes symptomatic. And this is an example of the device, which the class is called a stent retriever. And it does look very similar to that, those types of devices that are used in the cardiac world, but a little bit different. We access the groin typically, snake the guide wire through the clot itself, and then we push the catheter through. The people who are using this procedure or doing this procedure or performing the surgery or the procedure are interventional neurologists, interventional neurosurgeons, interventional radiologists. They deploy the retriever. As the device is deployed, it opens up and we see a cross section of the vessels and it opens up those vessels. And antegrade flow occurs when this device is deployed. We let it sit there for about 5 minutes, and then we try to retrieve the clot. So approximately at the internal carotid artery, we balloon occlude the vessel, and we pull back. And then we pull the clot out. So this is the standard, and this is an example of what a stroke patient can look like. The occlusion is here. We see lack of flow, lack of anobolization, and now we see the middle cerebral artery open. And this is the clot size, which is about a centimeter, maybe a little bit more than a centimeter total, which is considered a large clot. We also noticed earlier this year, in April 29th, in the New England Journal, that they presented a series of COVID patients having strokes. And this is our experience of pulling out a clot in a COVID patient. We talk about being hypercoagulable. Typically, a large clot is a centimeter, 3 millimeters, 4 millimeters, a centimeter max. This was 30 centimeters. And it was actually longer than this. This is what we actually took a picture of. And we've treated several patients in pulling these types of clots out of COVID patients with ischemic strokes. So it does, that disease state does cause a hypercoagulable state. We try to treat more people, and in some states in the US, they are using CAT scans in the ambulances to try to treat patients earlier. And that has been shown to be effective, but it's quite costly to have all of this available in the ambulance. Also with telestroke, and the system is set up, there's a central hub, a smaller hospital. At that smaller hospital, a stroke presents. They call the central hub. A person hops online and uses the assistance of a nurse to help obtain the history perform the NIH stroke scale, they look at images and make the determination if a person should get intravenous TPA or not. And if the person does reach certain criteria, they are offered transportation to the central hub for catheter-based therapies. But telestroke is a very effective way of giving access to smaller hospitals who don't have neurologists or interventional services. With blood pressure-related issues, we do know that most strokes are not eligible for TPA. So in the first few days, we let the blood pressure ride high. We're not aggressive with controlling that blood pressure. After a few days, yes, we do start to get it under control, but it's really a long-term type of process. And especially if we don't know what's happening with the vessels, let that blood pressure ride high unless they're having cardiac issues or respiratory issues. After 2 or 3 days, we know what's happening with the vessels, yes, we can get it under control. Those patients who have been treated or are eligible for TPA, we do want their blood pressure under better control because of that risk for hemorrhagic transformation. Blood pressure control is really a primary preventative tool and a secondary preventative tool, and we can reduce the likelihood of people having less strokes by being more aggressive with their overall blood pressure regimen. With antiplatelets, we have several to choose from. Aspirin, clopidogrel. The third bullet is the Igonox compound. And the fourth one is cilostazol, which is typically thought of as an agent used for peripheral arterial disease. But we think of these agents as secondary prevention, not primary prevention, like aspirin does for heart disease. This is only for secondary prevention after people have had events. For certain types of patients, of course, we want the dual antiplatelet therapy. And this was that initial trial. This allowed or brought up the idea that we probably should be treating some patients with dual antiplatelets. So in this trial, patients were loaded with aspirin and clopidogrel and given this 3-month trial. There was no increase in hemorrhages. Patients were above age 40. We see their ABCD score of 4 or greater, and they had small NIH scores. And overall, it was effective, but that was only one trial. There were several other trials since then, and we now know that the dual antiplatelet therapy probably should happen for at least 21 days or roughly a month, followed by monotherapy with just aspirin. So for all small strokes and TIAs, this is the treatment. With statins, statins are important for primary prevention and secondary prevention of ischemic strokes. Even if their cholesterol is perfect, we do want them on some amount of statins because they do tend to get some benefit from the anti-inflammatory effects of statins. There are models of stroke centers. Please be aware of what is available in your neighborhood. With AFib and stroke, it seems that there was this study years ago in the New England Journal. For those patients that were monitored for 24 hours, they found AFib in 3% of cases. But when they looked at an event monitor over 30 days, they found that 16% of those patients had AFib. And it seems that the longer that they evaluated these patients, the more AFib they found. It is not clear right now how long we should monitor patients with these peripheral devices. And we are not at the point where we are recommending patients get these implantable devices looking for AFib. But this is something that has changed therapy because in this particular trial, those patients did have higher chances of having AFib, and the amount of anticoagulation used did definitely increase. So this was really a game changer. But a whole cottage industry has been created regarding implantable devices by cardiologists. And like I said, as of now, for neurology, we are not encouraging that, but definitely longer monitoring. I think a minimum of 2 weeks, maybe even up to a month or a little bit longer. When patients are discharged, they're on blood pressure control with adequate amounts of all agents. We do like diabetics on ACEs and ARBs. With antiplatelets, hopefully they're at least discharged on at least dual antiplatelets if they're small TIAs or strokes. For larger strokes, it might be just antiplatelets monotherapy with statins, and of course, the lifestyle changes that we always talk about. We know that we're going to see more of these. Many of the definitions that we once used of old TIAs are really strokes. And I think imaging is really important. We now have a radiographic marker, just like cardiology they have biological markers. With troponins, we have radiographic markers now. We can treat more people in the secondary prevention world, and also with catheter-based therapies. Instead of the 3-hour window that we once had for IV-TPA, we know we can treat IV-TPA in patients up to 4.5 hours. And with catheter-based therapies, we can go at least up to 24 hours, but it depends on the type of imaging that they have. And Holter monitors, we should be using a lot more in Holter monitors. So this is the kind of a flow chart of everything, and I think my key points, and this is my last slide. Thank you very much, and I look forward to answering some of the questions that you may have.
Okay. Okay. Can you hear me?
Yes,
Yep.
I can.
Okay.
He didn't do the ARS slides.
Oh, do you want to do your ARS slides at the end?
I can. I was under the impression that the audience would be able to have a copy of the slides, can do that on their own. But typically, there are quite a few questions from the audience regarding the way we are treating TIAs and strokes, because it's something very different than the way we used to treat people even 5 or 6 years ago.
Okay. I mean,
If
it's
there are
up
no
to you. If
questions, we can-
you have time to do 1 or 2 of your ARS and take some questions.
Okay,
So
sure.
why don't you do
I will-
one
I
or
will
two, and then we'll start the questions.
Okay, I will move forward. So here's an additional question. Mr. Jones has 4 hours of sudden onset of dysarthria and his arm and hand weakness, and then his symptoms completely resolve. So A, is this, so here are the choices. A, is this a stroke? B, is this a TIA? C, is this a RINE, which is a reversible ischemic neurological deficit? D, is this a complicated migraine? Okay. The answer, if I press forward here, the answer is A. Really, the definition of TIA is less than 1 hour of clinical symptoms. And I think for those of us in the neurovascular world, this is something that we taught in neurology for many, many years, but we realized that it is really not a sensitive tool like we once believed. Give you an example. A couple of summers ago, I was getting a haircut. Right before I got there, my barber, who was in his early 30s, had neurological symptoms. People at the barbershop said it was maybe 10 minutes. He had slurred speech, right arm was heavy, and when the ambulance got there, he was back to normal. I went to see him later that day at his local hospital. His exam was normal. I examined him myself. He talked about, well, they told him it was a TIA. He had an image of the brain with diffusion weighted image, and it turns out to be a stroke. Even though it was only 10 to 15 minutes of symptoms, we can't hold on to time like we once did. So really, it's going to be about imaging. True TIAs are those patients who have symptoms, yes, but have negative imaging, negative MRIs. And so those are true TIAs. There are some patients that truly do have those types of symptomatology, but they are more rare than we once believed. Let's go to the question number 2. What is the most practical cerebral imaging study within 3 hours of stroke signs and symptoms? Is it A, CAT scan of the brain, B, CT, CTA of the head and neck, C, MRI of the brain, D, MRA of the head and neck? So in answering this question, what is the most practical cerebral imaging study within 3 hours of having stroke signs and symptoms on examination? The answer is B, CTA, CT of the brain, CTA of the head and neck, because the patient is still symptomatic. We don't know if this is a cerebral hemorrhage or if it's an ischemic stroke. We're usually good 80% of the time at guessing, but we never know. And we want to look at the brain, but since we're concerned about vascular related issues, we also want to look at the vessels as well. That's incredibly important because there are many patients with transient symptoms, and many times we're thinking, okay, was this a TIA or a small stroke? Was it a beginning of a migraine or complicated migraine? Was it some type of seizure? Was it some of the other mimics? The patients are diabetic. Were they becoming hypoglycemic? What really caused some of these symptoms? So, but if we're getting this type of scan, the patient's actively symptomatic, we want to get a CT of the brain, CTA of the head and neck. Carolyn, do we have any questions from the audience?
We have a lot of questions.
Okay. That's
yeah, there were a couple of questions regarding the dual antiplatelet therapy.
Yes.
One question was, just find it here, what do you do with someone who is already on dual antiplatelet therapy for some other indication, who then has a TIA or stroke while already on that therapy? How do you treat that person?
Okay. First of all, many of these patients, or some of the patients that we all see, probably 10 to 15%, regardless of all of our therapies, they will continue to have events. It is not, we don't consider those to be medication failures, but we want to sure up that their workup has occurred and that it's not something else happening. So we will, those patients are already on dual antiplatelet therapy. We do want them to have their imaging. We do want them to have their cardiac echo to make sure that there's no wall motion abnormality, because sometimes we do see clots in the heart or some other type of cardiac issue. And the Holter monitor, we want to make sure that they don't have any signs of AFib, because that will change therapy as well. So if this is truly a cryptogenic stroke, and this is an older patient with risk factors, we continue that current line of therapy. There's nothing more to change. They're already on statins. They already have great control of their blood pressure. Their diabetes or their glucoses have been fine, and they don't have any other obvious risk factors. But I think there are some patients that if they are younger patients, we would want to consider things. If they're young women, we would want to make sure that they are not on oral contraceptives with estrogen-based compounds. We would want to take them off of the oral contraceptives if we're concerned about vascular events. And also, we would perform hypercoagulable workups in those patients. And in that workup, when we perform an echo of the heart, we look for patients with patent foramen ovale, because for those patients that have had strokes and no obvious other great risk factors, there's some evidence to show that we might need to have that patent foramen ovale closed. Not all cases, because we know that PFOs, patent foramen ovales, are very common in about 25% of the population total, but in very selected patients. So it depends. But unfortunately, there are some patients, regardless of our therapies, they will have events. Just like when people have CABGs, their bypasses, we don't say 5 years later to that surgeon, Joe, that Mr. Jones that you did surgery on, yeah, he had a heart attack. Your surgery sucked. You did a bad job with that CABG. No, it's the disease. And what we're trying to do is stop the disease. We can't reverse it, but hopefully we can stop it or at least slow it down.
So you mentioned the PFOs, and there was a request from a cardiology fellow. We get so many requests for TEEs in patients in their 70s and 80s who present with stroke to rule out a PFO. Is there any indication for this? Does it really change management knowing that someone may have a small tunneled PFO?
The answer is for older patients, the answer is no. But for young patients, the answer is maybe. So for those patients who are below age 55 or so, that is something that is being considered more now, but it's not absolutely certain that they all should have things closed. And it's still almost a case-by-case type of scenario. But making sure that in those patients, hypercoagulable states are performed and that they have great control of those other risk factors as well.
Okay. Hopefully, just two quick questions here.
Sure.
What do you have an LDL target when you're treating with a statin for stroke? And if so, what is that? And also, please explain why strokes seem to be going up in prevalence in these younger patients. So first about LDL, any targets in stroke, and then younger prevalence of stroke. Why is that happening?
For LDL targets, this is something that certain cardiologists have used. There's no evidence that this is something that's efficacious for the stroke patient, because having elevated cholesterol isn't as strongly linked to stroke as it is to heart disease. Remember, we're dealing with a different organ and it reacts differently. We do know that the class of statins, it's themselves, they reduce stroke, but the link between cholesterol and stroke isn't as great. And also, there are many different causes of stroke. So overall, there's no recommendations that we should be pushing the LDLs down to certain levels, as it is in heart disease. And the second question,
prevalence in younger patients getting strokes.
Yes. I think this is something that has always been an issue. Even more than 25 years ago when I was a resident, as a neurology person, we would rotate through Children's Hospital of Boston, and they would have one pediatric stroke per week. And so this was 25 years ago. I think now because of news and social media, we hear a lot more about it. And of course, our population is growing. But like I said earlier, that 10 to 15% of our strokes, even in the adult hospitals, are in their 20s, 30s, and 40s. Typically for young patients, we think of the etiology as being number one, arterial dissection, which is incredibly common. Hypercoagulable states is probably the second most common, and then cryptogenic strokes afterwards. But it is unfortunate that it does happen. But unfortunately, we do see it. They may have some risk factors, but most do not. Most do not.